Dear colleagues, dear friends, good afternoon. I am Costas Tsouifis, Professor of Cardiology in the Athens University, Greece, and Director of the First Department of Cardiology in the Hippocrates Hospital. It is my great pleasure to share with you my thoughts on this topic about the 2023 guidelines for the management of arterial hypertension. Many thanks to organizers for this kind invitation, and apologize for not being able to be there in person. This is my conflict of interest, and before discussing what the new edition of European hypertension guidelines say for the management of hypertension, I would like to make clear that always presentation and publication of hypertension guidelines is of high importance for many reasons. First, and the most important reason is related to the fact that hypertension is a very common disease. High prevalence of uncontrolled hypertension worldwide. We see here data published in Lancet from worldwide show that only about 20 to 25% of hypertensive patients have controlled their blood pressure. This is true for women and men. And also recent data from this HECMO snapshot that we performed last year in Athens, in Greece, among all cardiological clinics, we see here that 68 to 76% of patients being hospitalized in the cardiological clinics has the history of high blood pressure. In other words, hypertension is a major contributor to cardiovascular morbidity and mortality. And also, let me remind you that the history of hypertension guidelines in Europe starts in 2003, when European Society of Hypertension, European Society of Cardiology produced their joint guidelines. The second edition was in 2007, and the third edition in 2013, and the fourth edition 2018. But this year, 2023, the European Society of Hypertension presented in the annual meeting of this society in Milan their own guidelines for the management of hypertension. And we expect the guidelines from European Society of Cardiology next year. This is the edition of the new edition of guidelines, which is published now in the issue of December in the Journal of Hypertension, the official journal of European Society of Hypertension. And these guidelines have used different criteria to define the level of evidence as when the evidence was classified as when randomized controlled trials or meta-analysis of randomized controlled trials with cardiovascular outcomes were used. And the level B, when randomized controlled trials with surrogate measures were used. So when we compare the different recommendations, we have to take into account this important change, and always we know the class of recommendation 1, 2, and 3, and also here there is a change. We don't have some categories in the class of recommendation 2A or 2B. We have only class 1, 2, and 3. Having said this, I selected to discuss with you 4 topics which, according to my opinion, is of high importance and are, let's say, innovative in this edition of the guidelines. First, what the guidelines says about blood pressure targets, how to achieve blood pressure targets, and the third point that I will discuss with you all is the management of resistant hypertension and the use of renal denervation. Starting with the office blood pressure targets, again, the hypertension guidelines recommend for most patients to target below 140 for systolic and below 980 for diastolic. But avoid go between below 120 for systolic and below 70 for diastolic. I think this is a very well justified blood pressure targets, taking into account the huge variability associated with blood pressure measurements. And going how to achieve the blood pressure targets, the hypertension guidelines recommend all four categories of antihypertensive medication: RAS blockers, ACE inhibitors or NBS, diuretic, CCPs, and beta blockers. And also, the guidelines recommend additional drug classes with, let's say, a general antihypertensive effect, like the steroid MRA, loop diuretic, alpha blockers, centrally acting, and vasodilators. And the specific comorbidities are ARNI, SGL2 inhibitors, and non-steroid MRAs. And this is the most important, let's say, slide of these European hypertension guidelines. We see here that the therapeutic algorithm for the management of hypertension starts with dual combination for most hypertensive patients at the initial visit. The guidelines recommend to prefer single pill combination at any step of therapy. In case that the blood pressure remains uncontrolled, then the guidelines recommend to switch from the dual combination to a triple combination. And if the blood pressure remains uncontrolled, despite treatment with a single pill combination of 3 drugs, then we have the case of true resistant hypertension. What is interesting to pay attention is that by using a double combination, about 60% of the hypertensive patients will be controlled. And with the triple combinations, this percentage will reach to 90%. In the end, only 5 to 10% of the huge pool of hypertensive patients will remain uncontrolled. It is interesting also to say that the guidelines give space for monotherapy in selected patient group, those with low risk hypertension or high normal blood pressure and very high cardiovascular risk, or in case of frail patients and patients who are very, very elderly. Beta blockers can be used as monotherapy or at any step of combination therapy. At this point, let me discuss very shortly how to lower blood pressure in hypertensive patients with heart failure with preserved ejection fraction. We know that HFpEF is in a way synonymous to what we name hypertensive cardiomyopathy. And hypertension is present in all patients with HFpEF in a percentage more than 92%. The same therapeutic algorithm is followed in patients with hypertension and HFpEF. But apart from the single pill combination, dual or triple combination, the guidelines recommend to use SGL2 inhibitors from the first visit. These drugs should be included in the basic therapeutic algorithm. Also, it is interesting that the hypertension guidelines provide recommendations about treating hypertension in patients with atrial fibrillation. In this case, we have to take into account the value of heart rate. In case that heart rate is over 80, RAS blockers with beta blockers should be our first choice. In case of lower values of heart rate below 80, we can use RAS blockers or with diuretic or with CCBs. And coming to the acute stroke, there is no difference compared to the previous edition of guidelines, but also it is in the guidelines provide a recommendation in those patients with ischemic stroke who are eligible for thrombolysis or mechanical thrombectomy. And going to the last, but not but so common comorbidity, patients with hypertensive patients with chronic kidney disease, we have to take into account the stage of CKD. In case of stage 1 to 3, we use, let's say, the same algorithm as it is proposed in the general hypertensive population. In case of advanced CKD disease, stage 4 and 5, then loop diuretic is recommended with RAS blocker CCBs in the first stage, and in case of true resistant hypertension, thanks to the CLIC study, chlorothalidone should be the preferred choice of diuretic therapy. Having said that, let me spend some time to discuss the therapeutic algorithm for treating hypertensive patients with resistant hypertension. In this case, the guidelines recommend to take into consideration the value of GFR. In case of GFR is over 30 and patients not controlled with a triple combination, we can add spironolactone thanks to the pathway to results, or beta blockers or alpha blockers, or centrally acting agent. What is interesting is the fact that for first time in the history of hypertension management, the history of hypertension guidelines, an interventional approach is also recommended. As we see here, the guidelines place here this algorithm. After having the diagnosis of true resistant hypertension, apart from selecting spironolactone or beta blockers, also the guidelines recommend to consider renal denervation if GFR is over 40. This threshold of GFR is placed there thanks to based on the patients that were included in the trials of renal denervation, where the patients with reduced GFR were excluded. This does not mean that renal denervation does not work in the setting of chronic kidney disease. There are preliminary data from single-center studies supporting that renal denervation is a safe and efficacious therapeutic option in patients with hypertension and reduced GFR. Now studies are running to test this hypothesis. In case that GFR is less than 30, renal denervation is not recommended, but in this case, as I mentioned previously, we can add chlorothalidone, which should be the preferred diuretic, along with loop diuretic for treating high blood pressure. We know that renal denervation is supported by the favorable pathophysiological background. Kidney are very rich innervated by postganglionic efferent and afferent fibers, and by disrupting both afferent and efferent fibers, we can enjoy a reasonable blood pressure reduction through many mechanisms. And we know that renal denervation has ups and downs. In 2019, renal denervation was considered as an amazing therapeutic method to reduce the high blood pressure. But the first randomized sum-controlled trial, the STN3, was neutral or negative for renal denervation due to the many confounders related to the standard population, to the catheter used, and also to the different levels of medication and years. And fortunately, the industry, along with experts in the field, designed the second generation randomized controlled trials, some controlled trials of renal denervation, which proved that renal denervation works. As we see here in this slide, the last years, the last 5 years, we have a number of randomized, some controlled trials testing safety and efficacy of renal denervation by using different technologies, radiofrequency energy by using the spiral catheter of Medtronic, or ultrasound energy by using the Paradise catheter by Recor. And in different clinical settings, in hypertensive patients naive of antihypertension medication, as well as in hypertensive patients with 1, 2, 3 or more medication, renal denervation achieved a clinically significant blood pressure reduction of 8 to 10 millimeter of mercury in office systolic blood pressure, of 5 to 7 millimeter of mercury in ambulatory systolic blood pressure reduction. And we see here the consistency in blood pressure reduction regardless of the technology, regardless of the study population. Now we have solid evidence that renal denervation could reduce the high blood pressure. And this is the two technologies that were used and were tested in a reasonable number of clinical trials: the RF catheter, the spiral, and the Paradise, the ultrasound catheter. We see here an example. My center has a great experience in the renal denervation by using both systems. Always we perform an aortography at the level of the renal arteries in order to exclude the presence of the accessory arteries, which is present about 20% of hypertensive patients has more than 2 renal arteries. And then with the elective engagement, we advance, in this case, the spiral catheter in the proximal part of the branch and the main stem in both renal arteries in order to disrupt sufficient number of fibers and to enjoy a significant reduction in blood pressure. As I mentioned previously, the average reduction of blood pressure post-renal denervation is about 8 to 10 millimeter of mercury in office systolic blood pressure. But this is the average reduction. There are some patients where we can observe a significant reduction by 20 to 25 millimeter of mercury, but also there is some patients where the blood pressure is not changed, or even the blood pressure is raised post-renal denervation. But what is interesting about renal denervation is that this minimal invasive procedure is not related to the adherence to medication, as is the case in the pharmacotherapy. We see what we name always on effect, an homogeneous reduction in blood pressure during daytime and nighttime, and we know that nocturnal hypertension is associated with an adverse outcome. Also, we have solid evidence that this blood pressure reduction post-renal denervation is durable at least for 3 years in the setting of clinical trials, or at least in 5 years in the setting of the Global Simplicity Registry. Up to now, we are not able to identify a phenotype of hypertensive patients which should be better responder to renal denervation. But what we know, that if we follow the recommended algorithm by at each one of these two devices, we will be able to produce a significant reduction in blood pressure. And we know from the pharma trials that even this blood pressure reduction, which is a moderate reduction, a minimal reduction, could be translated in a significant beneficial effect in the outcome of the patients, 14% decrease in stroke and 7% reduction in mortality. Apart from the blood pressure reduction, renal denervation is associated with a number of pleiotropic effects, and it seems that renal denervation could be of great importance in treating a number of conditions associated with hypertension and accompanied by increased sympathetic activity, like atrial fibrillation, sleep apnea, these metabolic conditions, chronic kidney disease, and particularly chronic heart failure. And based on all of this data, the guidelines provide recommendations for renal denervation. Renal denervation can be considered as a treatment option in patients with eGFR over 40 who have uncontrolled blood pressure despite the use of antihypertensive drug combination, or if drug treatment elicits serious side effects and poor quality of life. Class of recommendation 2, level of evidence B. And renal denervation can be considered as an additional therapeutic option in patients with true resistant hypertension. Class 2, level of evidence B. This represents a very, let's say, innovative recommendation with clinical application in the everyday practice. And also, the guidelines provide two important statements for renal denervation. First one, selection of patients to whom renal denervation is offered should be done in a shared decision-making process after objective and complete patient information. And the number two statement, renal denervation should only be performed in experienced specialized centers to guarantee appropriate treatment selection of eligible patients and completeness of the denervation procedure. Last month, a couple of days ago, FDA provided approval for both systems for the treatment of hypertension. Approval of the Paradise ultrasound renal denervation system, approval of the spiral catheter by Medtronic. So now we are ready for use in the clinical practice in order to reduce the high blood pressure and save more lives from heart attacks and stroke. That based on this recommendation, nowadays the treatment of hypertension in 2023 includes three pillars. First pillar, lifestyle changes. Second pillar, combination therapy. And in case that the blood pressure remains uncontrolled, guidelines recommend to consider renal denervation as an additional therapeutic option. Renal denervation is not alternative to antihypertension medication. Renal denervation should be additive in order to have a synergistic effect to reduce the high blood pressure. And with that, I would like to thank you all for attending my talk and to invite you all to attend the 10th official pre-SH Congress Satellite Symposium entitled Update on Difficult to Control Hypertension and Related Comorbidities, which we organize every year in March in Athens. Thank you so much for your attention.